Okay, yeah, my name is Brock Miller, new faculty at UT Health San Antonio. We're going to be talking about chronic abdominal pain 101 here. The title, obviously, wow, this hurts. It hurts for your patient. It may sometimes hurt for you, too. But I think when we all work together, we can actually make a lot of benefit for these patients. I have no financial disclosures. I also want to let you know I volunteered to give this talk. I am not a chronic abdominal pain expert, but I think after 16 years as a gastroenterologist, you actually become very good at dealing with some of these issues. Typically, I'd like to be talking about pancreas divisum, right, Stalin, or fecal microbiota transplantation for things other than C. diff and all these sort of fancy talks. But sometimes we just have to get down and get back to the basics. And I think especially with a reinvention from retiring from the military and going to the academic side, it was worth kind of trying to do one of the more challenging ones. And I also think after my review of all the literature and kind of looking through our society guidance, I've decided that I kind of think about this topic a little differently than many. We'll see if we can kind of tease some of those things out. These are some pictures of the hospitals that I've really learned to deal with chronic abdominal pain. The top left is the University of North Carolina, which is where I did my fellowship. We actually are considered kind of one of the main facilities nationally because Doug Drossman, who started the Rome Foundation, did his fellowship at UNC and was faculty there for decades, and one of my main sort of mentors in learning these sort of techniques. I went to Elmendorf for 3 years, top right, to do kind of a utility tour for the Air Force, and then have spent the last 10 years in our San Antonio fellowship sites, as you see on the bottom. And as I mentioned, I'll be transitioning to join South Texas Medical Center with probably many of you, and where I'll become the new program director of the GI Fellowship. I always look to our four main societies when I'm going to give a talk, and honestly, a lot of the time I do that when I'm going to see a patient with a specific condition to see what's out there, okay? So when you go to the acggi.org and you look for abdominal pain, it's blank, okay? You do find a lot of these guidelines, including the one that Dr. Owen just mentioned, the gastroparesis guideline. The two that I highlighted here are the management of dyspepsia and management of irritable bowel syndrome guidelines. Going through those, I also found acute pancreatitis, chronic pancreatitis. Of course, there's a bunch of IBD, Crohn's, and colitis guidelines, a celiac disease guideline, and SIBO. But you don't find anything for abdominal pain, okay? Well, let's look at the AGA, so gastro.org. This would be our highest sort of impact factor society. What do they have? You look for a chronic abdominal pain, and you get pain management in inflammatory bowel disease, all right? And then you see on the third one there is diagnosis and management of acute hepatic porphyrias. So we have a guideline for that, but not for chronic abdominal pain. These websites also have some nice resources to look for other things like lectures that have been given or other sort of resources. So the AGA University, you search for abdominal pain, no results, okay? And then going back to the ACG, and I'm fortunately be headed there this year to attend this conference, and I'd seen this in the mailing. They actually do have a 20-minute talk, so evaluation management of chronic abdominal pain and suspected IBS. So clearly, this term chronic abdominal pain does exist. And if you look at the AGA or ACG education universe and you look for abdominal pain, you do see a number of prior talks here. And what it looks like is every other year at the national conference, it looks like they try and put in a 20-minute talk on chronic abdominal pain. A lot of them are the same author, Brian Lacey. And then a couple other, visiting sort of lectures that people have given. So this is a resource. But it's very interesting because this seems like a topic that we're all thinking, oh, I have so many patients with this, but yet we really don't have a lot of resources. One of the resources a lot of the speakers in some of those talks and other people refer to is this paper from 2019, An Approach to a Patient with Chronic Undiagnosed Abdominal Pain by Dr. Pimentel. And I actually found this to be probably the best resource that I could find, especially since most ACG lectures do refer to this. I did do a PubMed search and try and find anything really great as far as a review article, but that's kind of missing too. So even though this topic seems like, oh, this would be one of the main ones, it's not really that well represented in our literature. Now this chart here, this is interesting, and this is where I kind of came up with this thought that I'm not sure that any of us really agree exactly on chronic abdominal pain or how to approach it. This is from the 2020 ACG talk by Lin Cheng. And here, she put the reference to that same paper that I just showed you on the bottom from Dr. Pimentel, but yet this chart doesn't actually exist in that paper. She says, in undiagnosed chronic abdominal pain, if it's diffuse, then you consider a centrally mediated abdominal pain syndrome or narcotic bowel syndrome. You got two options, right? And if your patients aren't taking narcotics, they don't have narcotic bowel syndrome. If you go to the right and you're looking at localized pain, they say do look for Carnet's sign. If that's negative, consider functional dyspepsia or IBS, and if it's positive, chronic abdominal wall pain. So I don't think Dr. Pimentel, because this isn't really in that paper, really agrees with this either, but I think, part of where I think differently about this is I think chronic abdominal pain is a symptom that we're going to have to pour into and talk to patients and figure things out. But it's not as simple as this, because this doesn't include really any of the things. Of course, we see functional dyspepsia and IBS, but any of the other things that these patients could have. So if you took a picture of this one, you can delete it. My apologies to Dr. Cheng. So here's my objectives. Quickly review the pathogenesis of abdominal pain. Let's see if we can define it. Talk about the H&P, discuss the differential based on factors, know the alarm features. That's probably one of the most important things. To know what Carnet's sign is, all right? That might be one of the absolute most important things from this talk. Let's describe an initial workup, and then we're going to review some conditions, especially the functional disorders. I think in essence of time, to try and go into treatment, I think a lot of us have a lot of extensive experience using neuromodulators and all sorts of treatments for chronic abdominal pain. But again, because this topic is so spread out, I think it would be very hard to nail down exactly how to do that. So we will not be doing that a lot of that here today. All right, as far as pathogenesis, there are pain receptors that lie in the abdomen, and there's really two different stimuli that can affect those receptors. There's chemical stimuli and mechanical stimuli. The main mechanical stimuli is stretched, okay, and that makes sense. So you overeat or something results in kind of a pinching in your abdomen that would be uncomfortable. There's also distension, contraction, traction, and compression. So you can think of a lot of the conditions that you might see, if you have volvulus or one of these sorts of things where that's going to be uncomfortable, right? But yet we eat every day, we drink every day, and we're not having discomfort from that. So it's really one of these sorts of things happening that's going to result in discomfort. There are visceral receptors on the serosal surfaces within the mesentery and within the walls of your hollow viscera. And then the mucosal receptors primarily respond to chemical stimuli. And that's what I just mentioned. If we were eating and every single thing that passed receptors that in your mucosa was uncomfortable, then we would all be in chronic abdominal pain. When you get those sensory inputs, they travel along visceral afferent fibers into one of three main thoracic splanchnic nerves, and then they end in the dorsal horn of the spinal cord. The visceral afferents are the source of nociception, and they spread across a broad range of dorsal root ganglions. So this is why neuromodulators would be effective, right? Because you have that stimulus, it goes along to the spinal cord, and then it's going to your brain for you to get the sensation of pain. Non-referred visceral pain is usually dull, poorly localizable, and midline. And this is one of the things that, and I think diving into this talk, I actually learned a lot myself. Splanchnic innervation is bilateral. So typically, if you have non-referred visceral pain, it should be midline, okay? Because you're going to get signals going both ways. So not necessarily right lower quadrant, left lower quadrant. And so even patients with things like inflammatory bowel disease and a stricture, a lot of times may sense things as midline because of that bilateral innervation. And the viscera has fewer nerve endings than the abdominal wall. So the abdominal wall is very important to think about, and I think the last thing we think about, but a very common cause of abdominal pain in our patients. This is from that same paper. We actually pretty much just went over all of this, but this just shows the visceral stimulus on the left, whether it's chemical or mechanical, cruising along those nerves to the dorsal root ganglia, to the dorsal horn of the spinal cord, and then heading up towards the brain. Here's a quick example. So if you have something in the small intestine causing pain, those signals enter the spinal cord between T8 and L1. So kind of depending or regardless of where in the small intestine, usually the pain will present as periumbilical. And again, midline because of the bilateral innervation. Pain that is clearly lateralized is actually most likely from the kidney, ureter, ovary, or a somatically innervated structure, okay? And the exceptions are the gallbladder and the ascending and descending colons. They are bilaterally innervated, but they actually are, it's kind of, there's one side will be stronger than the other. So that's why patients with gallbladder pain will typically point you to the right side. And probably patients with diverticulitis or something happening in the left side of the colon will point you to the left side. Referred pain is typically aching. It's perceived near the surface. You get skin hyperalgesia and increased abdominal wall muscle tone. So clinically, abdominal pain is a challenge. It's typically benign, but it can herald severe pathology. And our role is to determine which patients can be safely observed, be treated supportively, or require additional investigation or expert evaluation. The H&P, which obviously all of us have to do every time we see a patient for the first time, the real point of it is to develop our differential and determine what are the most likely options. So you may see a patient and think, I think this is probably a functional disorder. But at the same time, it's only been going on for 3 months. Everything else in their life seems perfectly stable, so they may require some investigation. The sensitivity and specificity has actually been looked at and is generally poor. But it's better for very specific etiologies. So if you do an H&P and especially you add in a little bit of an investigation, now it's a little unfair because they say for the appendix, you do an H&P and a CT, you almost always get the diagnosis. Of course, the CT is probably the main factor there. Here's my number one recommendation, something I talk to our fellows a lot about, and I think I'm always excited when they're going to go to small MTFs and kind of figure out how to run clinics. Like a lot of people in this room I've seen have been able to do. But I think we struggle with it a lot, especially in training, is continuity, okay? So I think you seeing a patient first time, getting that full history, getting your differential in your mind, knowing you maybe need some investigation and continuing to move forward is going to be a lot more beneficial than you see them and then 4 to 6 weeks later they see somebody else, and then 4 to 6 weeks later they see somebody else, because you're not actually moving along that pathway to really getting them either the diagnosis or the treatment they require. As far as acute versus chronic, there really is no strict time period or definition. There's no guideline, right? So there's a bunch of people who've given talks at ACG, and there's some papers here and there, but there really isn't a guideline. Typically, it's accepted pain of less than a few days or accelerating is acute. If it's been unchanged for months or years, I think we'd all agree that sounds chronic. I'll tell you, the ACG 2022 lecture says that they use a cutoff of greater than 3 months, but I don't know what you do if it's 8 or 10 weeks. That seems pretty chronic at that point, too. And then, of course, you're going to have subacute, plateaued, intermittent, acute on chronic, all sorts of varieties of pain. So there aren't really strict definitions. Now, Dr. Delaney used a mnemonic as well, and I hadn't thought of this one probably in a decade, but they use the one Socrates for abdominal pain. So what's the site, location, onset, character? Is it radiating? What associations are there? Typical things we'll ask in a GI review of systems. What's the time course? How long does it last? What's the frequency that it's occurring? How many times per week? Those are the criteria you're going to need to make a diagnosis of a functional disorder. What are the exacerbating or alleviating factors? So meals, bowel activity, motion, running, exertion, certain twists and things that people do with their bodies, and then, of course, severity. As far as the location, it makes sense. We all know the anatomy of the body, but right upper quadrant, we think biliary, hepatic only if with capsule enlargement. So we know most liver conditions would not be painful. In the epigastrium, you got peptic ulcer disease, dyspepsia, pancreatic conditions, which Dr. Eagle will talk about shortly. Left upper quadrant, so splenic, of course, there's not a lot of splenic etiologies, but things can happen. And then lower abdomen, you've got the lower intestinal tract, IBD, IBS, constipation, diverticular associated conditions, genitourinary, gynecologic, pelvic etiologies, etc. I gave a couple examples for the Socrates things here. So onset, these are, of course, mostly acute pain conditions, but if you had pancreatitis, it's kind of gradual and steady. If you had a perforation, it's sudden and acute. As far as character goes, peptic ulcer disease, we always use the terms burning or gnawing pain. Gastroenteritis would be kind of colic or crampy. Radiation pancreatitis, we know that classically it bores to the back, and renal colic to your groin. With SIBO, so as far as associations, you might get bloating and distension. I use mesenteric ischemia here twice because it's kind of hard sometimes to think exactly how to fit these things, but usually within an hour of a meal, your pain would start. Time course, so with IBS, it's typically intermittent. It's not a patient who says, I have pain all day, every day. They don't have IBS. Typically, that's going to be an intermittent condition. But it does need to happen regularly. And with something like chronic pancreatitis, it's fairly constant. Exacerbating and alleviating factors, so with mesenteric ischemia, it gets worse with meals. With IBS, when they're constipated, it's worse, et cetera. Some other things from the history, so coronary artery disease and peripheral vascular disease are very important to know. So chronic mesenteric ischemia, about 50% of people will have at least either coronary artery disease or peripheral vascular disease or both. As far as surgical history, what surgeries have they had? What sort of adhesions and things might be going on in their body? Plus, if they've had their gallbladder removed, you can kind of remove that. You still might need to think about the biliary tree, but as a source for their pain. As far as meds go, run their list, including any sort of alternative meds and over-the-counters, and look at their side effects. It's very common that medications could be causing a lot of their GI symptoms. And of course, we all know to ask about NSAIDs and opioids. Those can be pretty devastating to the gut. As far as family history, there's genetic syndromes and know if there's similar pain in family members, because that may help you pin in some of these rarer conditions. Social history, alcohol, drugs, so those can lead to obviously things like cirrhosis and downstream, sequela, including pancreatitis. And then abuse history or other sort of a lot of psychosocial issues that will play into the functional disorders without a doubt. And then as far as our review systems, let's figure out those associations and any systemic symptoms like B symptoms, weight loss, of course. I think that one of the other main things to take out of this are the alarm features, okay? So when patients, all of a sudden, 55-year-old comes in and says, I've had a perfect life, just retired, but I've had terrible pain for 3 months, that's a really significant alarm feature. If it's severe, it's progressing. If they have unexplained weight loss, of course, we immediately think, like, could this be cancer or some other sort of devastating condition? Nocturnal pain. So if they can't sleep at night, a lot of your functional patients will, do fine. They sleep at night and they wake up and maybe things start again, right? Recent change in bowel habits and especially GI bleeding. Okay, so we're all going to know, like, okay, you've had pain, you're 33, I don't think this is a bad thing. Oh, now you're bleeding. We need to do some investigations to make sure it's not IBD or another condition. Carnet's test. This is my only slide about the physical exam. So Carnet's test differentiates abdominal wall pain from visceral pain. So you want to find the point if they have, this is really for a patient with localized pain. I don't think it's that helpful if they say the whole thing hurts. But if they have localized pain, then you want to actually, put them on an actual exam table. You would be palpating in that location of their localized pain with them either raising their legs if they're able or kind of crunching their body, pulling their head and shoulders up from the exam table. If the pain actually gets worse or it's unchanged, then this is pretty much evidence that it's abdominal wall pain, okay? Whereas if the pain gets better, then now you're concerned that it's a visceral source. This is something I talk with our fellows a lot about, and maybe everyone knows about this. I've always said, especially when I'm working with an internal medicine resident, if we're going to, look at the basic testing that I might be considering today for this patient with pain and a lot of digestive symptoms, I think of the C's, okay? So a CBC and CMP, that covers almost everything. Are they anemic? Do they have leukocytosis or leukopenia? Are we concerned about their liver with thrombocytopenia? We get the full liver panel, right? You get to know if there's any metabolic problems. So their bicarb is even important. And then, you also will know, is there any issue or concern with me doing additional testing? So you get the creatinine. I think that one of the most important markers for disease is albumin. So if the albumin's normal, but somebody's had pain for 6 months, I'm not as concerned as if their albumin's 3.1 or 2.8. Now I'm like, let's image you soon, okay? CRP and calprotectin to think about inflammatory conditions. I don't think everyone needs a calprotectin, but I'll tell you if I'm doing phlebotomy on patients for a CBC and CMP, I'm often going to get a CRP as well. CT scan or other modalities. So that may not be up front, but that's something I consider a lot for pain. And then I list colonoscopy here, which I think is actually a pretty poor test for abdominal pain. But if a patient has those other associations, they're seeing blood in their stool, they're having weight loss, it's located in the right lower quadrant, you want to take a peek in their ileum, those sorts of things would be very reasonable. And of course, an endoscopy as well, if it's more of an epigastric sort of situation. Okay, I do want to mention these real quickly. We're at 22 minutes. These are, I was going to avoid this because I'm like, these are rare things and we're not going to see rare things. But then I thought about it a little bit and I kept seeing it in many resources. So we'll go through this very quickly. These are things that a lot of these resources list as potential causes of diffuse abdominal pain that are systemic diseases. In parentheses, I've included whether or not I've ever seen it and kind of the frequency in my mind of when that's something that I've come across. So you've got familial Mediterranean fever. This is inflammation of the serosa. So most people will actually have abdominal pain. In fact, 95% of people develop recurrent bouts of pain in addition to fever. These are from some Mediterranean countries or descents that you can see there. Sclerosing mesenteritis. Okay, I've never seen familial Mediterranean fever, by the way. Has anyone? Okay, there we go. But you've heard of it now. All right, sclerosing mesenteritis. This is an inflammatory or fibrotic disease of the mesentery in patients potentially who've had surgery, trauma, malignancy, or other immune disorders that can predispose to this. A majority of people will have abdominal pain. They can have other symptoms like weight loss and altered bowel habits. So I have seen many cases of that, not necessarily because we imaged them for their pain, but often because somebody else imaged them and they came to us like, what do we do with this, all right? Chronic mesenteric ischemia, 50%, as I mentioned earlier, have coronary artery disease or peripheral vascular disease. It's got a female predominance, and that's because of the orientation of the blood vessels in the aorta. So there are more acute blood vessel angles coming off the aorta, which actually predisposes to this mesenteric ischemia. Most patients will have postprandial abdominal pain, weight loss from fear of eating, nausea, vomiting, diarrhea. Hereditary angioedema, patients get recurrent bouts of angioedema without urticaria or pruritus. They can have skin mucosa or mucosa of the respiratory and GI tract involvement, which can lead to bowel edema and GI attacks, which occur in about 25% of patients. Really presents like GI colic. Have seen a patient with that. It was in a fellowship in a 1,000-bed hospital, right? Acute intermittent porphyria is an autosomal dominant condition with very low penetrance that affects the gene for regulating heme synthesis. The heme intermediates affect the peripheral, autonomic, enteric, and central nervous systems. So 85 to 95% will develop abdominal pain, but they can get chest, back, or extremity pain. And these patients typically will not have tenderness, rebound. They don't typically have fever or leukocytosis because this pain is neuropathic. It's the nerve that's affected, not the organs, okay? I'm seeing one case of that as well. Mast cell activation syndrome, consider this in patients with associated flushing, abdominal pain, cramping, diarrhea, are a result of mast cell mediators, the leukotrienes. They can get heartburn and nausea from increased acid from histamine affecting the parietal cells. Have not seen that one. And then Ehlers-Danlos, which is a heritable disorder of connective tissue that can lead to skin hyperextensibility, joint hypermobility. A majority of patients will have abdominal pain and other GI symptoms. Endometriosis, seen a number of cases of this, even within our military population. So 80% of women with chronic pelvic pain have endometriosis, and 10% of all women, so it's a very common condition. Typically, it's perimenstrual lower abdominal pain, dyspareunia, and often urinary symptoms as well. The data is very scattered as far as the frequency of GI symptoms, but it looks like it could be, close to a third. And if it's involved, it's almost always the rectosigmoid or the rectum, but can be the ileum, cecum, and the appendix. And then adhesions. So it's actually debatable if adhesions directly cause pain. We know that if patients are developing obstructions or other anatomic issues related to that could be uncomfortable. But experiments do show touching or moving adhesions does elicit pain sensation. And then, of course, benign tumors and malignancy. We're mostly thinking that those patients would have weight loss and other symptoms, but those are clearly things that we find as a cause for diffuse pain. As far as chronic abdominal wall pain, you consider this if the patient has chronic pain, it's unremitting, and it's unrelated to meals or bowel habits, but it worsens with position or movement. So I think you kind of want to get a gist of that up front on your very first H&P. This is 10 to 30% of patients presenting to a gastroenterologist for chronic abdominal pain. They can really undergo extensive testing and then still go on or misdiagnosed. And then Carnet's sign, we went over that pretty well, but it's 97% accurate for abdominal wall pain, and typically a positive Carnet's is less than 10% if the pain is visceral. So make sure you're doing that on every patient. There's a couple of the causes for abdominal wall pain there. Okay, and finally, we're almost done here, the functional disorders. This is kind of near and dear to me. I was going to bring one prop, but I happened to bring my first bin of gear over to university on Thursday, and this book was in it. It wasn't Rome 5, it was Rome 3. They've come a ways. But if you don't know much about the Rome criteria, it's actually pretty cool when you think about it. It's actually like up-to-date before up-to-date existed, all right? It's a continuous thing for really, the largest overall group of conditions that we have to deal with, right? Disorders of gut-brain interaction. So here's the timeline for Rome 5. It's okay because Rome 4 is out there, and if you go to the romefoundation.org website, you can get all their guidelines and whatever you might need. But they do a lot of fancy things, and I don't disagree with Dr. Drossman for the way he set it up. Getting to do all this international travel. But this is the Rome Foundation. They have 144 experts. They represent 27 countries from obviously numerous continents. And it started because of meetings in Rome so they could come up with the criteria. And Dr. Owen mentioned I would talk about functional dyspepsia, so I think that you do need to know these three very, very well. This is the criteria directly from their website. So you've got functional dyspepsia can be broken down into postprandial distress syndrome or epigastric pain syndrome. Those are things that are typically intermittent, but you do have one symptom or both, at least every week. And there's no evidence of structural disease, including an upper endoscopy. So most of these patients would get an endoscopy to exclude common things, perhaps blood testing and that sort of thing as well. Irritable bowel syndrome, this would be obviously probably the most common thing that we would see as an eventual cause for someone's abdominal pain, is recurrent abdominal pain on average 1 day per week in the last 3 months with 2 or more of the following. So it's related to defecation and a change in frequency or change in form of stool. And that has to have been going on for 6 months. So if your patient has only had symptoms for 2 months, they don't have IBS, they just don't meet the Rome Foundation or the Rome criteria at that point for IBS. And then lastly, you got centrally mediated abdominal pain syndrome. So this is really patients who just have continuous abdominal pain. It's not associated with eating, defecation. It's kind of limiting their function. It's not explained by other things, including the abdominal wall. So I think this would be, if you have somebody who has pain all the time, you want to think, is it abdominal wall or is it this? What you need to know, my last slide. So as far as the pathophysiology, we have a lot of receptors in our gut. You have chemical and mechanical receptors. They go through visceral afferents to the dorsal horn of the spinal cord. Acute is different than chronic, so is the workup and diagnosis. We don't have perfect definitions for these. We don't have a lot of evidence or guidelines for them either. The H&P is probably the most important thing in that continuity I discussed. Develop a differential based on the factors of their pain, know the alarm features, and do Carnet's test to see if they have a positive Carnett sign. The initial workup, I like the C's because it really kind of covers everything. I think a celiac panel up front is very important for young patients. Functional is the most common, but have an open mind both ways. So don't pin somebody with a functional disorder and not realize that this could be your first, mast cell activation syndrome or familial Mediterranean fever. But at the same time, don't give a lot of patients those diagnoses and forget that a lot of our patients have functional disorders. And then there's a bunch of systemic conditions that typically cause diffuse pain. Think about some of those as well. You've heard a lot about them today. Thank you very much.